Well, good afternoon, ladies and gentlemen. Excuse me. My name is Peter de Jong, and I have with me Professor Stephen Jeffrey. I'm sure you can see him. And we speak from a magnificent, warm, windless, and sunny Cape Town. I'm told it's going to be raining tomorrow, and we're desperate for the rain. But for now, as I look out the window, it's absolutely superb. I can see Devil's Peak. I can see Devil's Peak, and you've just dropped my phone, Steve, on the floor.
My phone, Peter.
Okay, well, that's all right. I can see Devil's Peak and Table Mountain, and it's absolutely wonderful, and I wish you could be here. I'm first going to say I'm hoping that people can come to SASOG, which is in August this year. Are you presenting, Steve, in
Um,
SASOG in August
I believe I
in
am, but I
Cape
think
Town?
they're still putting the program together, but I'll definitely be there. And I think we are involved in some talks.
Excellent.
Yeah,
That's wonderful.
I am,
That's
yeah.
wonderful.
So are you, and you?
Yes, I'm talking as well. And Steve, this afternoon's presentation is Incontinence. Your answers questioned and stump the professors if you can. So you're the professor, and I'm hoping people can stump you. So it is a free for all. People have asked us a few questions. One of these is, when are we going to have a question and answer session on incontinence? This is fecal and urinary incontinence. So it's anything goes. Your questions answered, and your answers questioned as well.
Yeah, that's great, Pete. So thanks. It is good to have everybody here. So this afternoon we decided to allow it to be way more interactive than our previous webinars. After last week's relatively non-interactive webinar,
Yeah.
we felt that we'd switch it around a lot
That's right.
today. And so we are already open for questions, and we know that the world of incontinence has changed a lot, and yet it hasn't really. So, and it's not something that we've really seen a lot of exciting positive movement over the last few years. But there is, we still see patients all the time. I mean, I saw 3 patients today who are leaking, various
Incontinence,
reasons. Yeah, various reasons.
leaking urine or leaking stool.
And in fact, a young girl of 30 with fecal and urinary
Oh,
incontinence.
both.
Yeah. So, Peter, it's not an unusual presentation. These patients are presenting to us all the time. And, I think we need to just get some sanity in terms of how we're treating these patients, especially internationally. I think there's a lot of chit chat and noise around the treatments that we do to
Yeah.
these patients. So,
Steve, it's absolutely true. Look, I see over here, I've already got my first question.
yeah.
As I said at the beginning, it's urinary and fecal incontinence, and somebody over here says they see quite a bit of obstetric anal sphincter injuries, or OAC as they're now known as. Is this always medico-legally negligent, or does this happen? And is it a priori? In other words, does it necessarily mean that if you have a third-degree tear and OASIS, or obstetric anal sphincter injury, is this by implication negligence? Well, can I just answer this, Steve?
Absolutely, Pete. I think you are more of the medical legal expert than me, so I'd love to
Yeah.
hear your opinion on that very question.
Well, now the funny thing is this: as we speak, Steve, I'm reading that excellent Bible by Abdul Sultan and Rani Thacker on pelvic floor damage and incontinence, and they have not only damage to the bladder, they also have damage to the rectum and rectovaginal fistula. And I think one of the most important things that you could take on board is OAC, obstetric anal sphincter injuries, are much more common nowadays for all sorts of reasons. Women are getting older, women are bigger, and there's a higher incidence of OAC in bigger women and older women. And also, importantly, babies are getting bigger and older as well. So if you have an older woman that has an increased BMI and her habitus is enlarged, you can be very careful that that baby is also going to be bigger, and you have to be very careful that you don't have an OAC. If you do have an OAC, Steve, it is not, in my opinion, medico-legally your fault necessarily. So you cannot be blamed for having an OAC. But what is important is you can be blamed medico-legally for missing it. And at the last FIGO meeting over here in Cape Town in October, we had a workshop by Abdul Sultan and Rane Thacker. And the point was made that it's not difficult necessarily to diagnose obstetric anal sphincter injury, OAC, as long as you have your own index finger. And although a woman can have that, it's not negligent, but missing it certainly is. What
Well,
you
it's
would
pretty
need,
easy to diagnose sometimes, Peter, to be frank, because I mean, you'll have a very big tear. Um, and I mean, what are the sort of tricks to seeing if that anal sphincter is indeed intact or not? Because sometimes, I mean, the tear can be quite bad. I mean, I know in private, you guys are a lot more maybe careful to do a more heroic type delivery, but I mean, they do happen, and these are sometimes things that you can't predict. But what are the things? I know my day, you try and see if you get a good sort of squeeze of the anal sphincter, but if the patient's got an epidural up, you're maybe not going to get that good squeeze.
but that's a great thing, having
And
an epidural. It means you could spend more time examining her with
um,
less discomfort.
and then obviously they talk about the pull roll
The pull
effect. Is
rolling
that is
technique.
that a very reliable thing to do or not?
Well, the first thing, Steve, is that you have to learn from Abdul Sultan's book the type of classification, because if you're not going to get the classification right, you're not going to know how to repair. So there's three A, B, and C. We're not going to spend time on repairing OAC, but what you do need to know is get hold of that book and read the chapter three is the one you need to read chapter three and see exactly how to diagnose it. It means that you have to have the patient in lithotomy with a good light and preferably with a sucker and an assistant. And you actually have to formally evaluate that anal sphincter with your index finger. If you can do that, and the woman can tolerate your finger, now she's got an epidural or a spinal, then you can see the depth and the thickness, which is most important, of the anal sphincter damage. And is it the external anal sphincter or does it include the internal anal sphincter? And if it's a grade 4, it includes, in fact, rectal mucosa. So from thence, you can decide if it's full thickness, you can do either the overlapping or the end-to-end anastomosis of the anal sphincter. And that's where it starts. If you do that, Steve, then you cannot be accused of negligent behavior. And even if things don't turn out to be 100%, because often they are not, she may still leak stool inflators afterwards in the future. You won't be medico-legally liable. But if you think it's a second-degree tear, repair it as such, and you miss a third-degree tear, and you don't spend all that time being careful and particularly attentive to her anal sphincter, you would be found guilty of negligence. So
So I
I hope
think
that comes from from anonymous. I hope the anonymous finds that useful. Spend the time, put her up, do the test with your finger. You don't necessarily have to have an endoanal ultrasound. I know they're available in this hospital, but you don't necessarily have to have it. It can be done, but if it's not done, use your index finger, and you'll be the vast majority of damage you'll be able to diagnose, categorize, and repair, Steve.
and I suppose I'm quite a big fan of a good examination, and I think going to look in theatre trumps many of the difficult examinations that you might do in labor ward without all the right equipment. Getting a patient to good lithotomy position, having good lighting, which you completely underestimate the value of good lighting in a theatre setting, and you will be most likely to repair that in a more robust way. I mean, especially if you're starting to struggle to see where's the sphincter is bleeding, you might still indeed miss it. So,
Well, that's
I'm
right.
quite
Yeah.
I'm quite keen. I mean, I don't do private obstetrics and I haven't done for some time, but I certainly think there's some value in going to look in a proper setting. I've never regretted going to take a patient to theatre to do a proper assessment. You see a lot more. But I mean, yeah, you guys are the obstetricians who are
Yeah.
there at night, and getting anesthetist out and things like that is
Well,
often not
that's a good point,
yeah.
Steve. That we're prepared to do any number of operations with assistants during the day. At night, something that's really important, especially to the quality of life for a woman like this under these circumstances. It's vital that you do have an optimized situation, including light, anesthesia, maybe an anesthetist giving a nice spinal, and an assistant in a theater that does have suction.
Yeah.
So that's where you'd start. If you don't have optimization of these points, you are almost doomed to failure.
So just in the defense of those who do miss the uh, sphincter injuries, though, Abdul also did another study with Van Zyl Andrews, who was one of his fellows, and they found there was a relatively unexpectedly high incidence of occult anal sphincter injuries, even when they weren't suspected at the delivery. And he had Vasant go to labor ward and scan patients who were
Yeah.
post-delivery. And it was, I can't remember the exact amount, but it was something like 8% or 6% or something. So it wasn't a low amount, and one does have to be quite aware of that. And but what do we do about that? I mean, as you said, we're not going to scan routinely.
No, but what you do, Steve, is that if you do miss it at a later stage, if you are in a privileged position as we are to have a colorectal surgeon who's adroit at doing the endoanal ultrasound scan and repairing it, that would be the right person. I don't think that I would, of course, in an immediate situation, I certainly would do the repair. But in the chronic situation, particularly if a woman has had this for several weeks or months, I would have thought that an endoanal colorectal chappie is the right person to employ under the circumstance.
Well, I mean, I think that then obviously takes us then to the next step and how these things unfold. And sometimes we do need to consider other options, and we do the Interstim, the sacral nerve stimulators, and they have actually become part of often the first line treatment
For what, Steve?
for patients with anal sphincter injuries. And especially in an older patient who's got fecal incontinence, we know that the repair of the anal sphincter, secondary repair of anal sphincters, at best on meta-analysis, after 5 years, less than 50% of them are still continent.
Yeah.
So, we are starting to look at the use of sacral nerve stimulation. As we call it, as we know, the Interstim is the one available in South Africa. And it's in many places it has become the first line, and we get good results with it. So that is something people do need to be aware of as well.
Yeah. Steve, talking about interstim and sacral nerve stimulation, what do you think is the place? Here's another question that just come up. What is the place of the interstim? Now, we're using this word, it is a commercial product. We're using it as one would use the word Xerox, for example, for photostatic. If you're doing a interstim, what is the place in modern practice for interstim in a woman with urinary symptoms? Now, you're a guy that has lots
That's
of
the big,
stuff.
yeah. I mean, that's actually there's a lot to say on that. I mean, that's quite a big
Question.
big question. I do a lot of Interstim in my practice. For those of you listening, it's not maybe something you might even have heard of, but it's in principle, it's a sacral nerve stimulator. I say to patients, it's a software upgrade for their bladders.
Software upgrade.
Yeah. So it takes the control of the bladder upstream, and we, through a small incision in around the sacral area, insert an electrode that then feeds through to sacral nerve root 3. Sometimes we'll catch 4 instead. It's done in theater, and we thread this electrode into the sacral nerve and then connect it to a battery that's implanted in the buttock. So it's a small battery. Actually, I even have one on my desk somewhere, but I don't want to be accused of marketing. But in principle, yeah. So it's
You've had it here forever. I thought it was a cardiac pacemaker.
well,
Is it not the same as a
it's made by the same company that makes pacemakers.
So you
And
could use an interstim or a cardiac pacemaker interchangeably.
not really, because technology is quite different.
Really?
But yeah, so it's basically just a little electrode that you put on your implanted in the patient's bum.
At this point, I might say Steve's running through his drawers.
Okay, but I don't have it now, so I don't think it should really necessarily focus on it. So what is it? Essentially, it's so you place this little pacemaker in, and
it looks just like a normal
yeah,
cardiac
it's
pacemaker.
about the size of
Matchbox.
yeah, that's actually good size. Good size to say, nice and flat, and we use it basically for patients who've got unresponsive overactive bladder. That's the main and primary indication for urinary incontinence.
So if your medical therapy for overactive bladder doesn't work, you have that. When would you use Botox and when would you use Interstim?
Fine question, Pete, because essentially you get into the algorithm of selecting either Botox or Interstim along the same way. So overactive bladder is treated very well in primary care, GPs, gynecologists, urologists, and I'm very happy with anyone who sees those patients presenting with urinary urgency incontinence, to have a trial of medication first.
Which is
For
what
therapy.
medication?
So we use, in my practice, first line is any of the beta-3 stimulants. So those of you who've heard of Betmega, Mirabegron is actually the generic name, and there is now luckily a number of generics. We've spoken previously on the same webinar about Erton, which is the generic of Bitmiga. It's about 250 rand a month now,
Oh,
but
that's not bad,
it's not
Steve.
bad,
It's
yeah.
about the price
Yeah.
of what's that old stuff that causes dry mouth and constipation?
Uh, VCK, yeah, well, it's Ditropan. Yeah,
Ditropan,
yeah.
yes. Oxybutynin.
Yeah, so I mean these are things that work well for patients with urgency and urgency incontinence, but at best, in those with severe incontinence, it might give them relief in only about 40% of cases. Just to go back a little bit further in terms of these patients, because I think it's important to realize that if a patient presents with a severe urgency and urgency incontinence, you do need to make sure that there's no other reason for it. So if you need to think about, ask about hematuria, make sure that they don't have cancer of the bladder, look at other, voiding dysfunction, something like that, that could potentially be other reason to think about a diverticulum or a stone.
Do they all have to be scoped, or can you
No,
maybe do a?
definitely not, Peter. Even if you get a primary patient presenting with severe urgency and urgency incontinence, if you've done a basic scan, exclude any urinary residual, you can do that with any ultrasound scan, and then you can then start them on any of the Erton or Betmega or something like that. The other drug that we have used extensively are the anticholinergics, and I'm sure everybody went through their training at UCT or Curtis or wherever they were, giving patients oxybutynin, and oxybutynin is still a drug that works. And
Genuine, are you being serious that oxybutynin is a drug that we can safely prescribe? And
we still use it. And in fact, I had a patient who from the UK of all places who came to me, and I think we did Botox on her, and she had Betmega, and she had VC care and everything, and then she ended up going back to the UK, and then ended up in a place where they gave her oxybutynin, and she wrote back to me saying, "Yeah,
there's
Dr.
a
Sebi,
new stuff called oxybutynin.
there's a drug that they've given me in England. It's called oxybutynin. It works very well. Have you heard of it?" And I
Yeah.
was surprised. But anyway, so let's not forget about the basics as well. So, but anyway, we're diverting a little bit, Pete, but let's come back to the fact that we know that we can give patients oxybutynin. It does work in about 40% of 40% of patients. You can go down to the next phase of a VCK or a Fenence. Did you know that there's something called Fenence, which is a generic of solifenacin?
No, I didn't know that, Steve.
It's a cheaper for the solifenacin. That's why Astellas is basically withdrawn from the South African market as
Really?
marketing. Yeah,
Because of generic.
well, their primary flagship drugs are now generic. So I mean, those drugs are up to 500 rand a month, but it's cheaper now. So
Steve,
Finance,
when can you not use anticholinergics? When is it contraindicated?
we know
Apart
that
from a woman that has terrible dry mouth.
well, the classic patient that you should not use an anticholinergic in is anyone with a closed angle glaucoma. So that is the main one that you do need to ask your patient about.
What about the elderly and children?
You do need to be careful. I mean, I don't treat children, to be honest with you, but so you do need to be careful. But they do use the trepan in kids. Um, and then
But
yeah, but you need to be careful. There are some drug interactions with some of them, so that's why I do prefer Betmega.
and when would you not use Betmega? What are the contraindications for
It's a
Betmega?
much cleaner drug, to use a term that you might have previously used as well. But again, anyone who's got uncontrolled hypertension, you must not use it in because there might be a slight increase in blood pressure. But
So what about using the smaller dose, 25 instead of 50?
that's where the 25 does come in.
Oh,
But maybe just for those of you who are prescribing mirabegron, whether it's Erton or Betmega, start on the 50 milligram. Don't sort of titrate it up from the 25 to the 50. The 25 is for those with contraindications or those with high blood pressure. So
oh, so you start on the
I
50.
always start on the 50. But don't
I
start
like
on
to
the
start on the
25.
25.
Unless there's a real indication to go for the smaller dose, go for the
Is it
bigger.
cheaper? The half dose.
Probably not, because I remember VCK, which is another Astellas drug that was 20, the 5 and the 10 were the same price.
But you
So,
can't break them in half because um,
well,
they're coated with something
yeah,
that
our
with
patients
a
would take
laser.
a 10 milligram every second day, and they were halving the price there.
Yes,
Yeah,
but they are
so,
quite long acting, Steve. So you could
yeah,
certainly,
yeah,
I mean, I know people that take it when they go to church. Um,
yeah, it's a good idea.
going to church.
That's what I meant. And it's a good idea to take.
No, so you could,
Take it
you
before
don't have
church.
to run out during the sermon. Well, I run out during the sermon anyway,
Really?
but for different reasons.
Okay.
Stevie has
Yeah.
another. Sorry, have you finished? Because I've got another
No,
question.
but I mean, look, I mean, I just want to say, let's just finish the direct about a conversation because I know that a lot of people are seeing these patients, and I absolutely think that they should be treated primarily as a start I wouldn't say primary care because I mean, I know a lot of gynecologists and urologists are seeing these patients, and I think it is important to ask patients about these problems. I've got a checklist when I see patients. I think it's good to do that because otherwise there is a chance you forget to ask something, especially if you're in a hurry. And if they've got urgency incontinence, it's not a bad thing to start them. Look, it is a challenge sometimes because you'll get patients who will have a long list of medications they're on, and then to add another medication for them is for them, doctor, I don't like taking drugs. But anyway,
Do they have interactions, these anticholinergics or
everything
beta-3
everything's got
stimulants?
interactions, Pete.
Is it?
Things do have interactions, but I say to them, try it for 2 weeks, try it for a month, see if it works, and we'll have a lot of patients phoning for the repeat scripts on these drugs as well. So that in itself tells me that they work. So
That is a
yeah,
very good way of knowing if the drug's
yeah. I mean,
working.
we often don't see patients back, and often we get a skewed opinion about what we're doing. But sometimes a patient not coming back is actually a good sign because
Like
it means
the
they're doing.
Noah's Ark scenario when you
Um,
sent out the dove
Yeah,
and
yeah. So I mean, yeah, it's actually another biblical analogy.
analogy.
Yeah, yeah.
Steve,
So
can
yeah,
I?
just about the
Oh,
Botox.
sorry, carry
Let me
on.
just
Botox.
finish this quickly
Okay,
because
finish up with the Botox.
Botox is another good use. Good, and we go quickly to Botox if these drugs don't work. And Botox is a great treatment for overactive bladder. The only trouble is that it does need to repeat it every 9 months.
9 monthly,
Yeah, every 9 months.
like pregnancy, should be repeated every 9 months.
But yeah, Pete, what I interrupted you very rudely.
No,
What
no,
were you
no.
gonna say?
No, you were saying Botox, and I just got a nice
Yeah.
question here on Botox. What sort of dose? I mean, do you do this yourself? Is it the same as a plastic surgery Botox? How exactly does it work? Is this for a specialist, or can any person that does cystoscopy give
I
Botox?
think in principle, it's a very easy procedure. Anyone who can do a cystoscopy can give Botox.
Really?
Yeah. Uh, the dose is 100 units. That's the standard dose. I have given up to 400 units in one patient. That is the maximum dose of Botox a human can tolerate. But
Before you die?
yeah,
Because this stuff is jolly,
well,
jolly toxic.
botulinum toxin is the most potent toxin known to man. Did you know that? It's used in chemical warfare. So yeah,
Where does it come from?
from the
Bees.
botulinum bacteria. Maybe Chris knows about this. Chris is a
Is that a lot of Botox?
no, Chris on our call here. He's on our webinar. He's but I think it's from the botulinum
Okay,
bacteria. It's a
so
bacterium. It's a toxin
You're
produced.
correct.
Yeah. Do you want to tell
yeah.
us a bit more about it? I don't know if you are a little bit more
Yeah,
familiar with
you've
it.
pretty much covered the entire thing there. It is the most toxic substance or toxin known to man, and it does come from that bacterium. That's about it.
Okay.
Okay. Yeah. Yeah. And I think Saddam Hussein had a few bombs with Botox in it.
Well, Wouter Besson was a registrar with me in Pretoria. I don't know if he's is he on the webinar? Wouter
Let's
Besson,
just check.
Dr.
Oh
Death.
no, I don't see his name here.
Yeah, he's a very famous guy in Cape Town, and he used to have shells for Botox
Well,
as a
he's
chemical
well,
warfare.
about to still in practice, and he's an excellent cardiologist. He um, refers me patients still. So
Does he?
yeah,
So you
yeah.
khabas with Wouter Besson?
I don't know him, but patients do. My patients do see him, and he's an excellent cardiologist. So
No, he is,
just
Steve.
to just to give you a little
I
bit of
can tell you,
feedback on one of our
let
colleagues,
me just tell you,
it's
but
great. Yeah,
my
yeah,
father-in-law went to Wouter
yeah,
Besson, and he
yeah.
lived to be
Yeah, and just from if we know that I mean he's still before the HPCSA and he's never really been found guilty. So we do need to give him that respect. So um,
respect to
but yeah,
both.
let's I don't think that's part of tonight's
No, no, that's
discussion.
not.
It's away from incontinence and it's quite a little bit of a controversial discussion there. But let's continue then on to the next question about the stress incontinence, Pete. I mean, Peter Young taught me how to do a TVT in the year 2000, and since then I've been
Done
doing
thousands.
yeah, and it's a wonderful procedure actually. And Pete, you still do them? You still like them? And what is your feeling? I mean, are we anywhere close to getting some sort of consensus that this actually is indeed still a very good operation? I
Well,
mean. The fact that it's had such a rough ride over the last few years. What are your thoughts?
Yeah, I don't think the actual tape itself, as the Type 1 tape, has had a rough ride in terms of the use as a mid-urethral sling procedure. I think it's been used elsewhere that has given it the rough ride. But remember, Steve, I do mainly obstetrics nowadays
Okay.
and Caesars and vaginal deliveries and lots of them, vaginal deliveries, more than anybody else.
That's good, John.
And so I leave that to you. But is, in your opinion, a mid-urethral tension-free vaginal tape procedure still the gold standard for stress incontinence that's failed physiotherapy intervention?
Absolutely, Pete. It still is. It is very far ahead of any other treatment options.
What about
Bulkamid.
yes?
Yeah, so I think we need to put all these treatments in context. And the reason I still book patients for TVT, I mean, in fact, I saw two patients this afternoon that are both on the list for TVT. And I think it's now been done since 2000 or in South Africa, certainly since 2000, when I remember Pete was doing them in Gretiskier. And in those days, it was still quite controversial. And so that was when we first started to do it. It's then been had some competition from the TVTO and the transobturator tape, but the retropubic tape it stands out head and shoulders above the TOT for a number of reasons. So
Give me those reasons. Why do you say classic retropubic, as first described by Falconer, Nielsen, and Umston, is
yeah,
better than the TOT, which is a transverse one done by Delorme and Waltregny and those guys?
so firstly, it's been shown to have better longevity in terms of efficacy. There's no doubt about that. The second thing is that there's a subset of stress incontinence that is called intrinsic sphincter deficiency, which is the other type of stress incontinence compared to the stress incontinence caused by hypermobility. So in a patient with a hypermobile bladder neck that has stress incontinence, they would do well, relatively well with a transobturator or retropubic tape. But in patients with a ISD, where the problem is more in the sphincter, they don't really do that well with a transobturator tape. Now, unless you're assessing patients properly
And
for
how would you make that distinction?
well, you would have to do urodynamics. You'd have to look at closure pressures, and you would probably need to do at least a ultrasound to check for bladder neck descent. Now, most people who probably aren't doing that, and that is why we still might find the odd failure of a TVT or TVTO. That all said, I think those people who did many TVTOs, like you did, and like I did as well, we found that they generally worked very well. I mean, you probably can't even think of one that failed in your case.
Okay, Steve.
But anyway, the bottom line is
Flatten-
that no, but the bottom line is it did actually work. So I think the bigger reason for me not doing them is that there is still a chance of a groin pain. For those of you who don't really know what we're talking about here, the one comes out retropubically above the pubic bone, the other one comes out through the groin or through the obturator fossa, just in on the outside of the pubic bones. How would you describe it, Pete? I'm maybe not
I
giving
think
it
you've
the-
described it well, Steve.
Okay. And they can get groin pain, and it was the groin pains that really gave these devices the bad medical legal press. And I suppose those are the things in terms of TVTs that have given it the most trouble by virtue of the fact that they get groin pain, and that is quite difficult to manage. You
How
can't.
do you manage it?
Yeah, I mean, Pete, I've seen quite a few over the years. You have to go in and look. I mean, the first thing is if you get it soon after the surgery. I've been in to remove tapes on a number of occasions completely, quite soon afterwards. If the patient has severe pain, then you are best removing it first because that's the best time. Within the first week you can actually pull the whole thing out. It's quite easy to take out. But leave it longer than a week and it's grown in and it's settled. So then you probably need to be a little bit more careful. But following that, you then need to try and assess where the pain is. Is the tape itself giving pain? And I still get patients quite regularly presenting with these symptoms. And then you need to decide, are you going to go and remove it? Then you can go, the easy part to remove is the vaginal section. That's actually very easy. I mean, you can get all the way to the pubic bone. But if the pain is going round to the obturator fossa and on the leg side of the obturator foramen, then you need to go and do a incision in the leg over that groin, which I've done a few times. And that is quite difficult because trying to find where that tape actually isn't easy.
Is the tape itself dyed, or is it this undyed
Well, the TVTO is
see-through?
blue,
Yeah.
so they made it blue because they knew that you might need to take it out. So that's what they
And the
did. So
TVT, the retropubic, is that also blue?
depending which brand you're using, but yeah, the J&J one is blue as well, and the Boston one I think is blue as well. So but the retropubic one is easy to remove. I've taken about 2 or 3 out as well. That is actually quite easy. You go vaginally, remove the vaginal portion, and then you go laparoscopic, and you can take the whole thing out. Not difficult actually.
And does it help pain?
It does actually.
Yeah.
I've taken 2 out as well. So that all said, I mean, you can see you can actually still get pain from both of them. But that is a trade-off for something that works, in my opinion, in at least 90% of patients. By working, I mean, this patients told me today that this thing has changed her life because um, she was unable to do her running. I mean, patients put on weight, they just really start picking up, becoming active, and exercise is actually a very important of people's quality of life these days. So
You're right,
and
Steve.
and it's the exercise that people want to do that makes them really want to get these things treated. It's not what you think. It's not the lady in her 70s and 80s is leaking. It's the 30-year-old, the 40-year-old, and the 50-year-old, and even the 60-year-old who I saw today who are leaking and can't get on with their daily lives that need to have something done for the leaking. And that's what we are treating with these patients.
Steve, when would you do bulk I mean, we mentioned bulk. What is the indication over TVT? It's
So
a lesser
bulk
operation. I don't think it's cheaper, but it's
for those of you who don't know what it is, we're talking about a bulking agent. So it's a periurethral injection of polyacrylamide gel that goes into the periurethra. You go with a cystoscope, you look at the bladder neck, and just about 1.5 centimeters away from the bladder neck, you inject a 0.5 ml of this polyacrylamide gel into 4 little quadrants. I'll go with we got like sort of 2 o'clock, 4 o'clock, 10 o'clock, and 8 o'clock around there, and it squeezes the bladder neck. And yeah, so it's a very inert sort of gel or agent, and the success rates are ranging from 40 to 90%.
a wide variety.
It's the first thing to say about it is actually very operator dependent. So it really very much depends on how good the injection is done, how well the injection is done. It was actually invented many years ago, in about 2005 already, Pete. When I was working in London, we were part of the sort of very first study on the stuff. But since then, I've noticed an improvement in the way it is actually injected. And it's very much dependent on how well you actually place that injection. And I think and also from personal experience, I think even over the last few months, I feel like I've improved my technique, and I had the rep from the company in my operating room nearly every time I did it. And they actually at one point said to me, "Listen, let's get um, a trainer in your they bring a pig bladder into your office and they show you again with a little bit finer detail on the technique." And that certainly has improved my outcomes. So even for someone like me who told them once that I've been doing this technique for 20 years, why do I need to get taught again? But I certainly saw the value of really understanding what they have learned over the last 20 years in terms of how it's actually given. So I want to give credit to the company for placing a lot of emphasis on the actual technique of injection. And if you get a good placement, you'll often get continence up to like 100%. So it's not bad.
Steve, no, it is undoubtedly expensive. I mean,
But it's covered by medical aids.
is it?
It's about double the price of the actual gel is about 14,000 rand, but whereas TVT is only about 7,000. But look, they come and they go. They'll come in and they'll go the same day, and the next day on the flight to wherever they live. I had a patient who flew back to PE the next day, and she was fine. I've had a patient go back to London a week later, and she really was fine, and she was dry. So it's not a bad procedure, but for me, it's the predictability of the TVT, the longevity, and just the fact that this is something that we know will probably work. Whereas the Bulkamid, we don't know, but there's almost no side effects or adverse events with the Bulkamid.
Steve, can you not use other forms of bulking agents? What about fat or blood or other less
Stem
expensive
cells.
options? Stem cells we know don't work, but what about fat or blood, for example?
Um, yeah, look, I mean, I think your generation was doing weird things like that, Pete. I think when I was a registrar, you guys used to talk about this at meetings and those old pelvic floor meetings you guys used to have. Captain
With
Charles, we
Stuart
thought,
Stanton and
yeah,
Linda
you
Cardozo and
guys were talking about collagen and all sorts of things, but I think those things all fell by the wayside. I mean,
yeah,
what were
well,
you
look,
guys doing in those
no, I
days?
tell you what, number one, you'd have to have such high pressure. Collagen is a protein, as you know.
Hmm.
Problem is you can get allergic reactions to
Yeah,
bovine
yeah, I know.
collagen, and
Yeah,
that was
yeah,
withdrawn because
yeah.
it's absolutely unacceptable. Putting in blood is so temporary, there's supposed to be no
Well, there's
use at
already
all.
blood there, so what's the
Yeah, well,
blood
you go
doing?
and put a little clot there. And the other thing is fat. You'd have to have such high pressure, thick needles that it also doesn't work. It
Yeah,
just leaches away.
yeah.
So those weren't ever
There
successful.
was
And the
a
macroplastique and the other spheres and these other
Durosphere. What was it?
Durosphere, all of those were such snake oil, they didn't work.
Yeah,
Valcomed is different.
there was a very bad product that came into Cape Town it was about 7, 8 years ago, and we were asked to do it at Groot, and we did about three or four, and honestly, I mean, I would be surprised if it wasn't just silicone that you can buy from Builders Warehouse. It was this like sort of stuff, and we ended up taking them out. It was a terrible thing, and we learned a big lesson about how we introduce products into our practice. It
Steve,
was it was
should you not do it, for example, using an animal model like a sheep that you can inject things in and see, A, does this cause a local reaction? B, does it leach away? And C, is it effective?
well,
Does it hang around and cause continence?
I think the important thing about anything that you do on a patient is that, just because they're doing it widely in Europe, or you get taken on a workshop, or one of your colleagues goes on a workshop and comes back with a technique, and you're told that these things are being done in their hundreds in Amsterdam and in Pretoria. There's someone doing a lot of them, and you know you come here and you want to do it, and they're telling you to do it in Groote Schuur. It's not. It doesn't mean you must do it, and you probably do need to be asking for that proper data, published in a good journal and showing me the adverse events. And I suppose that was where we really fell flat in a lot of things in pelvic floor surgery, and that is why we are still reeling at the bad outcomes from a lot of what we've done over the years, and why we still struggle to get funding for a lot of our um, operations and procedures, because and research. We don't have a lot of research in urogynecology anymore, because we had the opportunity where J&J, Bard, all these companies were throwing a lot of money at us, and we introduced products too soon, and we didn't advise them properly. We didn't give them the better runaround in terms of what we were demanding as surgeons, and we then got them into trouble in a certain way, with all the class actions, and we don't get the investment, and so that's why it will be very rare, Pete, to see something new. I mean, when last did you see a new procedure for overactive bladder, stress incontinence, or
I
any
think
I
the
wouldn't
last
say
thing
a
I
new
saw,
Mac?
the
I
last
mean,
thing I saw, or mesh aside, was the mini slings, the
yeah.
TVT Secure. What is the place nowadays, if at all, for mini slings?
Peter, these are all the things when you come down to the saying your answers question. I mean, there's another answer that we were given to stress incontinence, and I know there are still people on the call who might still not understand exactly what we're talking about with some of these devices, but the TVT retropubic, the TVT obturator, they were long slings that exited either through the suprapubic area or the transobturator through the groin. We were then introduced to the short slings that anchored in the obturator fascia. It was only about 5 centimeters long. And again, J&J brought in something called the TVT Secure, and everyone thought it was wonderful because it wouldn't go in the groin, it wouldn't go near the bladder, but it failed in about 70% of patients.
You did a review, a Cochrane review of
Yeah.
mini slings, Steve.
Yeah, so we, with two third-year medical students at UCT, we were the first to do one little meta-analysis on it that presented at FIGO, and that then spurned the first Cochrane review on comparing single incision slings to the main slings. And yeah, I think we've had about 4 or 5 sort of versions of that Cochrane review, which the last one was about 2 years ago.
And what is the bottom line?
The data on the newer TVTO versus the slings versus the mini slings versus the retropubic, it's not bad actually. And so I do use the single incision slings, and we have I use the Solix, which is a Boston product. I tend to use the Solix more during when I do a prolapse operation and I add a sling, I'll often do a Solix rather than a retropubic TVT. But as a standalone procedure, I still feel much more comfortable doing a standard retropubic TVT.
Okay, so the bottom line is don't do them, rather send them to somebody like Steve who can do a retropubic.
But Pete, yeah, I think that the important question for a lot of people is that there is a lot of traction and movement towards some of the other options, Pete. I mean, have you ever heard of the M-Seller chair?
Oh, you mean that chair that on which a person sits and then they cause muscular contractions?
Yeah.
I didn't know it was called an M-Seller. I thought it was just called a chair,
Yeah.
a seat. Does it work? We're lazy people intrinsically.
I'm not a good guy to ask because I had one as a placement job for 3 months, and maybe the patients that I see are those with sort of more advanced stress incontinence. It didn't really work that well, but you've got to look at the data on it, and if you strip it down to what I've read, it's works in about 20 to 30% of patients. But then again, if you're one of those 20 to 30% of patients who goes for your 6 sessions on the chair, the chair you don't even have to see a doctor for. You can book yourself in for the chair. You pay your whatever amount of money for it is, and then you go for your 6 sessions. It's like going to the gym or going somewhere. You just go and sit in the chair for 20 minutes. You walk out. You walk in your clothes, you walk out with your clothes still on. And if you can walk out with an improvement in joint stress incontinence after such a relatively non-invasive effort, I mean, why not? And I mean, if it was cheaper, I'm sure I would endorse it even more. But the chair itself is expensive. It's about
Very
about R1 million.
Yeah, I know.
But I
it's not
think
cheap.
I did look online. I mean, I think in Alibaba or something, you can get one for maybe 150,000 rand. So,
Made in China.
well, I mean, it might not be bad. Maybe it's the same factory that's making them sell a chair.
Yeah.
And maybe if it was cheaper and more accessible, if you could book it, maybe if you at the new Virgin Active you're on the point, they should maybe have a chair. They're doing all sorts of things there.
Yeah, it's
Maybe
true.
no.
Steve, I've just had a question here. You haven't mentioned physiotherapy for stress incontinence.
Sure, Pete. That's a very bad thing I've done there because look,
What is it?
we mustn't forget the fact that pelvic floor exercises are still one
Gold
of the
standard.
foundations of the treatment of anyone with pelvic floor dysfunction. And in fact, the good thing in South Africa is that we've got a very strong cohort of pelvic floor physiotherapists. If you go to the South African Urogynecology Association meeting, half of the attendees are physiotherapists. They're very interested, and whether you live in Joburg, PE, Bloemfontein, Hermanus, Belleville, or Cape
Or
Town,
Fresnay.
yeah, you will find a pelvic floor physiotherapist who will be able to help you. So it's and primarily, I think patients should go and see them first, maybe before they get into the hands of a surgeon who's just going to operate. So it's probably best managed at the level of a referring person, and maybe send them for physiotherapist first. It's always lovely for me when someone has already seen a physiotherapist and they've then made a decision that they need a surgery. So
Who, the physiotherapist or the patient?
the patient with a physiotherapist. But yeah, I mean, patients don't do well by just doing their own Kegels by squeezing their
Why
pelvic floor
don't
through
they,
it.
Steve? Why
Well,
can't
they
you
don't.
do everybody watches YouTube.
Um, Look, I mean, I haven't really done a lot of that research myself. I'm pretty sure if you looked hard enough, you'd find some good advice online about it. But the muscles the patients are exercising aren't really the right ones often, so you need to be trained. But my friend Jessica McKinney, who's a physiotherapist in the US, I mean, they were very far down the line of developing a little device that taught the patients how to
But
do
Steve,
this.
there's any number of those devices, little balloons you put in your vagina, and you have to squeeze, and then you've got a little column or a little bubble that
Yeah,
goes up, and
I mean,
there's variations on that thing that have been around for decades.
but look, I think there's a market for that and there's a scope for it. And you know, they were in Cape Town about 6 months ago with a company that had developed something that was very nice and they had some good data on it, where the patient would actually do it and it would be taught with this actual device. And it's you know, I think that is probably where we should be going a little bit with things like that. You know, patients physio like us. I mean, it's not very well reimbursed as an outpatient setting. The
What
patient,
physiotherapy?
yeah, the
Mm.
patients have to often pay out of their own pockets. Often
But
they
Steve, you only have to go to the physio once or twice. The rest you do at home. You don't have to go there every time. It's not like going to the gym, unless you've got a home
well,
gym.
Peter, it is a way in like going to the gym because those patients have to do those exercises at home.
Yeah, but you
And
don't do.
just go once off to the physio, they're going to show you. But I mean, the compliance and all the things, and that's probably why it doesn't work as well as we might read in the literature. You know, you'll find if you read the data on this, like 50% of the patients are improved, but not in data reality because the patients are busy as
In
well.
lived reality.
Yeah.
Yeah. Steve,
Yeah. Do we have any questions,
we
Peter?
do this. Let's just check over there. What does that
This
say?
question, yeah.
No, that's on Botox. But is there no? I've had a question here on prolapse. I don't know if you want to talk about that or to keep that for next time, Steve. Talk on a question on prolapse.
What's the question?
The question is this: in modern prolapse surgery, what is the gold standard for women that have got uterine prolapse? Now, you do a lot of prolapse
I do, Pete.
surgery. You do
Look,
it
I think
laparoscopically. You do it vaginally.
it's not an easy question because
So
you
it's a
know
good
for
question.
every single patient there's slightly different nuances and different preferences and different
Options?
options and also different prejudices. I had a lovely patient in her 70s, sexually active, was in a new relationship, and she came to me with quite a big uterine prolapse, and we spend a lot of time talking about it. And the bottom line is, if you really wanted to talk about a gold standard, and in principle, I mean, we all know the laparoscopic sacrocolpopexy is the best way to treat it from a outcome point of view and also from a recovery point of view. But we know it uses a mesh. So she didn't want a mesh procedure, and so we ended up doing a sacrospinous fixation,
Mm.
which is a good operation actually, and we did them for almost decades. I mean, you were the first one to show me it as well when I was a registrar. But she recurred within about 3 months, and you know, she was quite upset. But luckily, we had kind of spent some time together before the operation, and she knew that you know, this was actually a choice that she had made. So she's not coming for a laparoscopic sacrocolpopexy.
Well, Steve, it's about
Yeah,
managing expectations.
yeah. I mean, but then on the other side, you know, we've you know, when I was at Ski, we researched our outcomes of our sacrospinous fixations, and we had a success rate of more than 90%. So it's not a bad operation. So, but you know, if you want to do the best operation for someone, I mean, we know that a sacrocolpopexy is a good operation. It's good. Patient ends up with a good vaginal access. Sexual function is excellent. The mesh complications are very low, and indeed, if they do get a complication, you can manage it because you can find the whole mesh if you need to address any issues there. So,
Can you use mesh for anterior repairs or posterior repairs?
so vaginal
Yeah,
meshes,
vaginal mesh. I think that's the term.
I
Yeah.
don't I don't do them at all. There are some products in South Africa that are still
Sailed.
sold
Sold.
and used, but I think in my practice I don't do them at all. I gave a talk at the Saga meeting about this. I just don't use any vaginal mesh, and I don't think it's really defendable from a medical legal point of view anymore. So, but I mean, people are still doing them, and some guys like my colleague Frans van Wyk, I mean, he's an excellent surgeon, so he makes them work very well. And I mean, why not? If the patients get a good outcome and you able to prevent complications with whatever operation you're doing, then go for it. But I mean,
But
I don't.
even Franz van Wyk, who's is a good friend of mine, wouldn't do a posterior mesh, surely.
Yeah, I mean, I don't think anyone should do
No, I
that.
don't think anybody
And
does.
you know, I mean, anyone who's really following evidence-based medicine and common sense wouldn't do that.
Yeah.
Yeah. So yeah. No, I mean, look, there's a lot to talk about. It has been a little bit of a whirlwind.
Is there any place talking about physiotherapy? How good is physiotherapy for prolapse?
Look, I mean, I think the data does vary a lot. And I think for a small prolapse, it might improve the symptoms a little bit. But I mean, for a big prolapse, I don't think it really works very well.
You're wasting your time, are
Look, I
you?
mean, if you can see the cervix hanging out between the patient's legs, it's very unlikely that the physio is going to change anything there. But what will change something is a pessary, and maybe that's just the last thing we should talk about. I mean, I saw patients this afternoon who are put in a pessary as well, and she was very happy.
I know you use lots of pictures because
Yeah,
you always come and steal them.
well, I ordered some this afternoon
Oh,
too.
good.
I
Oh,
just didn't
thanks.
have the heart to come and steal yours anymore. So Pete's got a wonderful drawer of old pessaries. Some of them look like they came from
Kruitsky
I
Hospital.
think they came from the other hospital before Cretiscare. You know, what was that?
New Somerset.
You know, I don't know. They predate Cretiscare, those pessaries. Some of them are quite
Those old hard red ones.
yeah.
No, I wouldn't even use. I wouldn't use an old hard red one. I think nowadays the softer ones.
But your
But you
draw's
know,
still quite full there, Pete. I don't think you're missing any.
no, I know lots of pastry. Steve, it's the experienced chaps that's still. Now, and I absolutely agree with you that pessaries have a place. There's
Yeah.
many old women that I have that are walking around with pessaries, and if it doesn't work for them, then you can go for surgery.
Yeah.
There's no reason that you should always start
And
with
we
surgery, always end with pessaries.
and we mustn't forget to discuss pessaries with patients because if you offer them an operation and they were keen on a pessary, I mean that would really be a massive injustice to them, you know. And I've had patients who've been very obvious surgical candidates, and as you're discussing surgery with them in passing, you are compelled to mention a pessary, and you know you can't really judge a patient's feelings and what they're going to want. So you must always talk to them about a pessary. It's wrong to not do that. And I have one patient I've been managing her for 12 years on a pessary. And luckily, she did come to me as a second opinion. I was also obviously keen to operate on her, but I mentioned pessary, and she's been on a pessary for 12 years. And every time I change the pessary, she says, "Oh, I'm so glad I didn't go for an operation."
Yeah.
Yeah, so we mustn't forget about pessaries.
No, Steve, I
Yeah,
don't forget about pessaries. I'm,
yeah,
I'm a great
yeah.
pessary person. Have we got any more time? I think
I think we pretty much got to the end of it. I mean, it's only 5:02, but I mean, we don't have to use all the last 5 minutes if
we
we don't
can
want
save
to.
that for
Yeah,
next
I know.
time.
I think we run out of things to say about incontinence now. I think it's yeah,
And prolapse.
yeah.
Steve, it's been wonderful talking to you.
And you too.
It's
Yeah, yeah.
great to have so many people on the chat with us. We've got many hundreds of people on the chat, and thanks for
Oh,
all
here's
the.
a question actually from another anonymous attendee. Are you able to remove the bulkhead if patient asks to have it removed, not wanting something synthetic in the body? Anyone
Anymore.
uh, eh, anymore? Or if you feel you haven't placed it correctly?
If you put it
Uh,
in, can you pull it out?
no, you can't actually take it out. It's too no, I mean, it does get somewhat integrated, and I think the damage you'd cause by removing it would be, quite bad for the patient, and I think you'd most likely cause further weakness to that sphincter and worsen a symptom quite substantially. I think it would be better to counsel the patient about what she actually has in her body and, try and reassure her that, whatever she's got isn't doing any harm.
Welcome, yeah.
Yeah.
It's actually just sort of water-based, isn't it?
It's water-based, it's
Aqueous.
polyacrylamide,
Yeah.
and I think with someone like that, it would be really good to walk them through exactly what it is that they have and try and address the concerns that they are experiencing from
Well, if
that.
it doesn't work, it doesn't work. So then you'd actually go to TBT.
I had a patient who got a diverticulum following above a bulkhead though. So I mean, it's not entirely impossible for it to cause some problems, but yeah, I mean, it'd be interesting to know why that patient wants it removed. But
Well,
I'm
if it
not
doesn't
aware.
work, just leave it because it's a bit like
Yeah, Yeah, no, I wouldn't.
Yeah.
I wouldn't try and remove it. Yeah, that could be quite.
No, we mentioned stem cells that never took off because it never ever worked. What's that stuff the plastic surgeons use when they spin down blood and they get a plasma-rich protein plate?
PRP.
Yeah, that's the stuff.
So PRP was used in some patients for stress incontinence, but it's not widely used or published at all. But the place where it's used a lot is obviously for the other more sort of cosmetic and aesthetic practices.
But
So,
why does it not work in the urethra? If it works in a person's forehead or if they're in their frown lines and things, why would it not work in the urethra? What's the difference?
well, biomechanically, Pete, you need something that's going to increase the pressure of the bladder neck, and I just don't think it's strong enough to overcome that. That's why Bulkamid doesn't work in some patients.
Okay.
I mean,
Does
that's
it?
why you still get some patients who have a TVT and it won't work. I've had patients like that. You're just not getting enough pressure. I mean, that huge sort of force that occurs in the bladder and then overcomes the pressure in the urethra could just not be strong enough. But you know, there are simple things that have worked for stress incontinence before. So, I mean, I'm sure there are patients where it might work, but the PRP it's used more for the G shot. You heard about the G shot and the O shot.
Do they work? I mean, I know they're completely off center, off piste, but what is an O shot? I've heard of a G shot, is a Parthian shot.
I don't do any of them,
What's
but
an O shot? Where do you put an O shot?
they're sort of calling them G spot amplification
G
procedures.
spot, yes, but what
Dr.
is
Matlock in the G spot.
an O spot?
Well, I think it's to improve the orgasm, and so
Oh,
it's just
you
what
put
you're
the
using. So,
PFP in those places.
so I think a G shot is one of them is PRP. The other one could be some sort of hyaluronic acid, I think. So, but maybe we should get someone to give us a little bit of an overview on these things because
Do they work, Steve?
they absolutely work. But otherwise patients wouldn't be sort of queuing up and paying their however many thousand to have these procedures. I mean, there's
Is it not
doctors in
placebo?
the US. I doubt it, Pete. I think people are finding some use and some value, Pete. No, I'm not. Really don't want to criticize any of those treatments. If people are prepared to pay for something that would improve their sexual experience, who am I to criticize the doctor or the patient for having that? I
Hmm.
mean, why not?
Steve, you've got one more minute.
Yeah. So
I've just got a question here. What about laser for stress incontinence? Can you do
yeah,
it in a minute, Steve? Laser for stress incontinence.
I've used it. It works in very occasional patients. I do have a laser machine in my office. I don't actually even offer it to patients for stress incontinence anymore, but it has worked in a number of patients,
Do
and
you use it for what we used to call atrophy,
I use it a lot. It works extremely well,
GSM?
and I think it's a very good treatment for atrophy. I've been using it for about 10 years in my practice, but that's not something that we've got a lot of time to talk about. But for stress incontinence,
Answer is
I don't
no,
think we're there yet, but
not yet.
just to say that the Pelvic Floor Foundation is currently and very actively working on a new laser machine for stress incontinence. And in this very week, we've got our team from France, and we are actively doing our first phase trials on this
In sheep.
in an animal model.
Oh,
Yeah.
pigs.
We don't want to talk too much
Oh,
about
sorry,
how
you
we're
won't
doing
talk
it,
about it. Well, let's finish
but
then.
we've got some primary
Data.
research, and yeah, we can talk about that another time. But it's a very different technique, a much better laser, much deeper laser, and hopefully in the next 2 or 3 years, you might even have something on the market that you can all be using.
I'll
So,
be first in queue to buy your laser.
okay,
Well,
good.
on
Thanks,
that
Pete.
point,
Yeah.
Steve, thank you very much for sharing those insights. It's been wonderful to have you.
Pleasure, Pete.
And next week, we'll same time, same place, Steve. Thanks, Chris, for all your insights on Botox. And I look forward to having you all again. Same
Thank,
time, same place
thank you, Pete.
next
Do
week.
we know
Thanks,
what's on
Steve.
next week or not?
Yes, we have some things, but I cannot
Okay,
divulge.
we look forward to it.
Yeah, I have
And
some.
the following week is a holiday. We're still having one then on the
What holiday is that?
It's the 2 weeks time. It's the 30th of April. It's the
Well, if it's
day
a
we
holiday,
do.
we can't have one,
Well, it's
Steve.
holiday the next day.
No, we
So,
don't usually have it the night before.
okay. All right. So we'll
But
cancel
we'll
it
let you know
the
next week.
30th, I think it is. Okay, we'll
Oh,
check
hang
it
on.
out.
It's the end of April and the beginning of
Yeah,
May.
yeah,
It's a long weekend, isn't it?
yeah.
Yeah.
So we'll see. Okay, I think we maybe skipped that one. Okay, but anyway, we'll talk about it. Thanks everybody, and thanks to my colleague Pete for his ongoing enthusiasm and ongoing momentum he keeps with these webinars, and we look forward to the
Great
next one.
pleasure,
Thank you,
Stephen.
Pete.
As always,
Okay,
thanks
thank
for
you.
your
Okay,
mini bar,
thank you.
and we look forward to seeing you next week.
Okay,
All
sure.
the best.
Bye.
Thank
Bye.
you.
Bye.
Goodbye.
Bye.